Thanks. You can ask them some questions if you want. No? All right. Thanks very much for the invitation to come today to the launch. Jonathan Dodd's my name. I'm a cardiothoracic radiologist in Vincent's. I was asked to provide a bit of a flavour of some of the cardiothoracic imaging, clinical imaging research that we're doing down in the hospital. Obviously, in 9 or 10 minutes, it's very hard to cover everything. So I'm going to zero in on just giving a flavour of the sort of the larger projects that we're involved in. And I'm going to keep it to cardiac, just again, in the interest of time. You could give a whole other talk on the thoracic side of things. So the major clinical cardiac projects involve a couple of different imaging modalities down in Vincent's that I'm involved in. So I'm going to mention one project from CT, one from MRI, and one from cardiac PET-CT. Okay, so cardiac CT, lots of smaller projects, but one of the largest I'm involved in at the moment is a trial called the Discharge Trial. It's a European multi-centre trial. We're the Republic of Ireland site down in Vincent's. And it's essentially assessing the safety and efficacy of cardiac CT across the continent. It's got a decent grant, €6 million grant funding for it. We've recruited 3,500 patients. Actually, patient recruitment is finished now. We have all the Vincent's patients as part of that cohort down on the PAC system in the hospital. And there's also a core lab, which all the different sites have sent the imaging to. So all 3,500 patients are actually on the core lab database. It's a cardiology-radiology collaboration across the continent. There were 16 countries involved in the trial, 26 hospital sites. These are all the different sites around. You can see us here in Dublin. So a large database, somewhat unusual pragmatic trial database, and I'll just talk about the primary hypothesis before we talk about what we could do with it. But essentially the discharge trial is looking at the efficacy of coronary CT. Will it be superior to invasive coronary angiography in reducing major adverse cardiac events? And the reason that people think cardiac CT might be useful is that it's better at detecting and quantifying coronary plaque burden compared to invasive coronary angiography. This means the correct patient goes on statins, and statins reduce hard cardiac events. So that's the hypothesis of the trial, obviously a major question. The hard cardiac events that we're talking about are fatal and non-fatal myocardial infarctions, or heart attacks and stroke. And we're looking at patients at 1 year and 4 year follow-up, and we've done 1 year. And we're currently on year 3 of the second follow-up. There's obviously lots of studies and sub-studies you can do apart from that primary hypothesis paper. This is what a coronary CT looks like. You can see the aorta here, left main coming off here. This is, I look at images of this like this every day. Down the left anterior descending coronary artery, and here is a coronary plaque right here. You can see it's severely narrowed the lumen of the coronary artery here. And also taken off a little bit of the lumen of the diagonal branch coming off here. You can see that the plaque is a kind of variable density or different shades of gray. There's a kind of a high density in the center and there's kind of a low density around it. This is a so-called spotty calcification plaque. This is what people talk about when they're talking about vulnerable plaques. These types of plaques have a high rupture rate, and it's plaques that rupture that give patients thrombosis in the coronary lumen and heart attacks. There's an awful lot of interest at the moment in artificial intelligence, machine learning, in analyzing the plaques, analyzing the density of the plaques, analyzing the composition of the plaques, and even just detecting the plaques is a very topical area of research interest. Obviously, there's a lot of interest in improving the spatial resolution. We heard a lot in the earlier talks about spatial resolution detectors. There's an awful lot of interest in trying to improve the spatial resolution to visualize these plaques and so on. There's a lot of interest in radiation dose. Lowering radiation dose is one of the big advantages of MRI. We heard earlier over CT, and coronary CT is no exception to that. A lot of people are developing iterative recons to try and lower the radiation dose to get more signal out of lower X-ray photons. A lot of people are experimenting with low KVP techniques and different types of scintillation crystal detectors and different types of detector arrays to try and improve the contrast and the spatial resolution and so on. And obviously with this particular cohort, there's a lot of different scanners in a lot of different countries from all over from all over Europe. So there's a lot of potential to analyze the data and to experiment with the data. The core lab is housed in a hospital called Charité in Berlin. And just out of interest, a week or two ago, I got an email from the chief guy there, a guy called Mark Dewey, who's the principal investigator on the trial, to all the PIs that the core lab funding to maintain the core lab has been maintained by the EU for the next 5 to 6 years. So if there are students who would be interested in accessing the database of cardiac CTs, 3,500 of them, and it's all curated and maintained data on the core lab database in Berlin, then make sure you come and talk to me about the opportunities to try and do that. Yeah. I'm particularly interested in radiation dose, and I actually collaborated with the Diagnostic Imaging School here in UCD with a guy called Shane Foley some years ago on cardiac CT, and we did breast bandage, trying to move the breast out of the radiation dose field. So already some collaboration on cardiac CT with UCD, and hopefully future collaborations to occur. So that's one project on the cardiac CT side. On the cardiac MRI side, one of the largest trials I'm involved in on the cardiac MRI side is the trial called the Parable trial. This is, as far as I know, the largest database of diastolic heart failure patients in the world at the moment. We've got about 250 very carefully worked up patients with diastolic heart failure. Diastolic heart failure is a certain subtype of heart failure where the problem is not the cardiac ventricle contracting, but the cardiac ventricle relaxing. It's a major problem in heart failure clinics around the world. The Parable trial is actually a randomized drug trial of a fancy ACE inhibitor, which I know very little about, called an ARNI subreceptor type of ACE inhibitor. We've recruited 250 patients. Again, we've finished recruiting actually for this trial, and all 250 patients' cardiac MRIs, was actually 500 of them, because this is a before and after the drug, are on the Vincent's PACS system. We're doing it in collaboration with Ken MacDonald and Mark Ledwidge. Ken MacDonald's a clinical cardiologist down in Vincent's, and Mark is a pharmacist here in UCD. So again, I'm trying to emphasize, we've heard the word collaboration a lot today. A lot of the research works that myself and Rona are involved in are very collaborative, tends to bring about the best research. So here's a cardiac MRI just to show you what I'm talking about. This is a kind of a 4-chamber view: right ventricle, left ventricle here, left atrium here, and right atrium here. You can see the aorta here and spinal cord and so on. And their main primary endpoint is the drug changing left atrial volumes. In diastolic heart failure, left atrial volumes dilate and they become inefficient. And so the clinical cardiologists are attempting to use the drug to keep the left atrial volume low or small or within normal scan range limits. I'm very interested as an imager in looking at things like ventricular motion, obviously image quality. Again, I'm coming back to things like spatial resolution, contrast resolution, temporal resolution. These are all parameters that we look for in cardiac MRI. So you can see there's a kind of a bar here. This is what we're experimenting with at the moment. There's a yellow bar across the mitral annulus here. You can just make out the mitral leaflets here between the atrium and the ventricle. And what we're looking at is the dynamic movement of the mitral annulus towards the apex. And obviously, it takes a lot of time to manually do all this. And the potential for machine learning to automate this and to find out which parts of the bar are moving at the right speeds, which ones are moving at abnormal speeds, is it the medial side, is it the lateral side, and so on. Obviously, there's huge potential there. And we're looking at 4D phase flow in cardiac MRI as well. So this is where you're assessing the movement of the bloodstream and the path that the bloodstream takes through the heart and through the aorta. This is aorta here. This is another cardiac MRI of the heart here. You can see blood flow coming through the pulmonary veins and into the left atrium. In fact, there's an atrial septal defect here, so it's pathologically going into the right atrium. Again, subjectively with our radiology eyes, as Ronan has said, we can only glean a certain amount of information, direction. Radiomics and artificial intelligence has the potential to analyze the phase flows in much more detail than we can. So that's the Parable trial. And then the last trial, which is only just getting off the ground actually, is involving cardiac PET-CT. We're looking to evaluate coronary and systemic inflammation using PET-CT. PET-CT is traditionally a kind of an oncology imaging tool, but we envision it branching out into lots of different non-oncology applications. We've recently opened a cardiac PET-CT suite down in Vincent's, so a lot of potential for research. We're looking at two particular groups. One is sleep apnea and one is psoriatic arthropathy. There are large patient cohorts in Vincent's in both these groups, and both of these groups have a higher prevalence of cardiovascular events, heart attacks, strokes than matched populations without these entities. So I'm actually not a cardiac PET-CT reader and indebted to a colleague of mine, David Murphy, for the inflammatory PET protocol that we're going to try and use in these patients. And just to show you what I'm trying to get at, this is an axial FDG PET-CT. This is the aorta here, and you can just see little foci of FDG uptake, which is taken up in areas of vascular inflammation in the medial side of the arch of the aorta here. This is a nice normal aortic wall here where there's no increased uptake. The increased uptake is seen here in the liver as normal background. And again, here's another little hotspot of FDG inflammatory uptake in the aortic vascular wall. Very difficult to pick this up with CT, which is usually how we image in routine clinical practice CT. And here's a very new report, only out in the last few months in JACC, in two patients with psoriatic arthropathy. A and B are where it's mild psoriatic arthropathy, and C and D are where it's a patient with very severe psoriatic arthropathy. We know that patients with more severe psoriatic arthropathy have a higher heart cardiac event rate. It's a huge problem for these patients. And this is an FDG here. The coronary, the aorta here, coronary artery coming into the epicardial fat here, and no FDG fat uptake here. You can see around the coronary artery. You can see it outlined there with the dots. Here in the more severe patient, you can see there's subtle but definite abnormal FDG uptake in the fat. And it's turning out that for a lot of these heart attack patients, the epicardial fat around the coronary artery is actually very abnormal and inflamed. And again, we can pick up a certain amount of it with the subjective eye of the radiologist, but again, a lot of potential for machine learning to pick up much more subtle changes than we're able to pick up subjectively. And obviously, the potential to generate cyclotron tracers, specific cyclotron tracers, specifically for fat inflammation, or even coronary artery wall or aortic wall inflammation is obviously huge. At the moment, FDG is a rather generic inflammatory tracer, so a lot of interest in trying to develop more specific tracers to specific tissues. I'm really getting into terra infirma here. This is another colleague of mine who reads these MSK musculoskeletal, Eric Heffernan. But just, it's interesting to see, this is a CT hand on the left of someone with psoriatic arthropathy. You can see some small erosions here in the carpal bones. Another one here, the blue arrow, maybe a little bit of widening of the carpal joints. But if you look at the FDG, it's so grossly abnormal. These are all abnormal areas of FDG uptake in the joints. Here in the triangular cartilage, here in the tendons and muscles. And you often see this in clinical practice. You often hear patients who have very severe symptoms in their hands, and you do an X-ray or CT hand, and you really only see mild changes or sometimes no changes. So obviously huge potential here for PET-CT to develop beyond just simple non-specific inflammatory FDG pickup. So that is an absolute whirlwind through some of the cardiac projects we're doing, and we have lots of smaller ones, so happy to chat to everybody afterwards at the round table discussions and some of my collaborators in some of the projects. Thank you.